Hi.
Hello.
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 Hello, Anna Członkowska is coming. Yes, I'm already.
Hi, Hanne.
Hello.
Hello.
Hello, again. Hello. Hello and welcome everybody to the third rollout meeting in the Stroke Action Plan for Europe. I'm happy to see so many people here, and I'm happy to know that I've already spoken to some of you in the new one-to-ones that we are starting. As a part of the introduction, I want to give you just, an overview of the status. What have we done so far and what is left to do, which is obviously quite a lot. Next slide, please. So far, the publication by Bo Knowing came in 2018, which forms the basis of our work. This was a result of a collaborative process representing almost all countries in Europe, and many different professions were based on evidence and consensus, state-of-the-art, including problems at the time of the writing, as well as, for us most importantly, the targets for 2020 to 2030 was laid out. In August 2019, the Steering Committee for Implementation had its first meeting. Our aims are to set out a plan to facilitate that the aims of the action plan is met. And these rollout meetings are obviously part of this plan. We had the first kick-off meetings where representatives of scientific societies, as well as, very importantly, stroke support organizations, met first time. Afterwards, we had the first two rollout meetings in November and January, and now we have the last of the three rollout meetings in, well, today, February 2021. Oh, sorry, next slide, please. So far, we've been through a process of mapping stroke organizations and societies and now have a picture of that. National coordinators in the countries have been identified and have started their work by participating in these meetings, as well as their ongoing stakeholder analysis and the establishment of the network in countries. Recently, lists of tasks for the national coordinators, as well as deadlines, have been distributed. Last meeting, we discussed declaration and key performance indicators, and based on your feedback, these have been finalized. Further ongoing is the one-to-one communication, where I meet and discuss, talk on Zoom with representatives for countries, talk about the organization of the healthcare system, what kind of data they have for the quality part of SAP-E, as well as get an idea of their needs and how we can best assist them. This is actually an extremely interesting and for me, very giving experience to do, and I'm looking so much forward to meeting more of you than I've already done. Today, we will see a presentation of what we call the SAP-E tools, the learning platform, which will be presented by Christina Tui. Urs will present on the summary database platform, and Torsten Steiner will present the basic care manual, which has been prepared in collaboration with a committee set by the ESO Guideline Board. Next slide, please. As I said, well, forget what I put in my own slides, probably not the first. We're already ongoing with the interview with the national coordinators, and basically you are welcome to invite people with you whom you think would contribute. We don't want to be 100 people for these. This is kind of, a conversation where we can see each other into the eyes as much as you can on Zoom. But on the other hand, everybody are welcome. So it's up to the national coordinators who want to participate. And the Zoom link which is sent is not restricted to 1 or 2 or something like that. You can just involve the people who you think would help in this process. And the aim of this is, of course, for me to have the option of talking to you, which is not a possibility in these COVID days, but certainly also to provide the implementation steering committee with a systematic overview of a more systematic overview of the organization of stroke services and healthcare systems in the countries, and also what data are available on stroke easily. Next slide, please. The timeline, just to give you an overview for the next 6 months. The stakeholder analysis, we assume will be finalized during February. We have this third rollout meeting, and the national coordinator task have been set out. In this period, the national coordinators are forming the national networks based on the stakeholder analysis and in collaboration with stroke support organizations. The interviews or one-to-one conversations with the individual countries are ongoing, and we expect that these will be finalized before the end of March. A new official website, which will provide us with a very, very good tool of communication, both including learning facilities, the basic care manual, options for communicating with other people working with the same as those, as well as material on the process, and not to forget the platform for uploading data. This will be with an official launch in March, and we will give you the data later. The learning program and basic care manual will be finalized. We're aiming to get this published too, so that it has very, very easy access, and not just put it on the website, where we plan to have this set up graphically in an easy to use way, also with the option of easy download and printing for putting into the pocket or wherever you want to put it. In May, we will set a date for the official launch of the declaration. At this time, we will also be ready to contact the ministries of health. We have been postponing this during the COVID crisis because our gut feeling was that they would be hard to get at this moment. But on the other hand, stroke does not go away because you have another problem. Actually, the impression is that COVID might even have made stroke a bigger problem. By July, the national coordinators will have ended appointing the national auditing committees. By July also, the registry platform is expected to be working and have, and we will be doing dry runs on it. And in July, we will circulate a template for national stroke plans, as we have become aware that some countries do not have that much experience in making this kind of plans. So we're setting up a template to make this work easier. It is our intention to supply you with this kind of material to assist the process. And we are very, very open to have input from you if you feel there's something more we should provide you with, because we will then consider it very, very seriously if it is something which is possible for us to do. No more slides. So I will go back to the, so this was basically the introduction today. The theme is the tools, and the first talk will be done by Urs Fischer on behalf of the Implementation Steering Committee. So Urs, please take the word.
Thank you, Hannek, dear colleagues, dear friends. So it's my pleasure now to give you an overview how we would like to collect this SAPE summary data. Before we start, I would like to thank also Hanne for helping me to preparing this presentation, and also most important to Diana in Portugal, who was extremely helpful in this whole process. We all know that the Stroke Action Plan, I think it's probably the most ambitious project ESO has ever done. But on the other hand, I also strongly believe that's probably the most relevant and most important program we ever did. And you see, we have 7 domains in the chain of stroke care which we want to improve. It's primary prevention, then the organization of stroke services, the management of acute stroke, secondary prevention, rehabilitation, life after stroke, and the evaluation of stroke outcome and quality assessment. And we have the document which has been published in 2018 after the meetings we had in Munich, and we have set the targets. First of all, we want to have a common European framework of reference for stroke care quality. Second, we want to have national representatives, which means these are you who are the ones who are bringing the stroke care in your country forward. Then we want to have establishing a national regional level system for assessing and accrediting stroke clinical service. And last but not least, we want to measure whether we are going to improve something. And if we want to measure this, this is a major task. So the efforts to improve the system or process of care must be driven by reliable data. And how can we get reliable data? That's the first thing which we will briefly discuss now. So we want to know what exactly needs to be improved, because that can be different in various countries. Not every country has the same challenges. And we also want to see whether our efforts are leading to an improvement. So in 2030, we want to look back and we want to see whether the Stroke Action Plan really could be implemented and whether we could change the fate of our patients and improve the system within Europe. So we want to identify the problems. We want to prioritize the quality improvement initiatives. And again, this will be targeted to different countries. We want to enable objective assessment of whether this change and improvement have indeed occurred. And last but not least, we need this data to influence policymakers and stakeholders. So what are we going to collect and how are we going to collect this? So we had a long discussions also in the steering committee what we want to discuss. And we have 2 options. Either we can really go down to a patient level and try to measure the stroke care in individual patients throughout Europe. This would probably too ambitious and not feasible, mainly also because we have the GDPR issues. So therefore, the steering committee has decided after a long discussion that we will focus on summary data and not on individual patient information, because this would simply be not feasible. We have decided that we want to focus on basic variables and key performance indicators. There are a lot of interesting things which could or should be measured. However, at the end of the day, these projects needs to be feasible, and therefore we have to limit the workload and the collection of data on the data which we think are most crucial. And last but not least, we have to collect data, the same data in all different countries, because we do want to see whether there are differences across countries and over time. So we now have to define a core data set, which we now will collect over the next 10 years. So what are the basic variables? Obviously, we want to see what are the overall numbers of strokes within a country. You know that even the information we do have from the Global Burden of Disease reports, we have some data on ischemic and hemorrhagic strokes in different countries, but you also know that the data quality behind these Global Burden of Disease data are often heavily criticized by individual members of different countries. And what we want to do is we want to improve the quality of the data of number of strokes overall in Europe. We do not only want to know the strokes, we also want to know the TIAs and the hemorrhages. We want to see what is the mortality, the gender distribution, and the age ranges. So these are the basic variables which we would like to collect. And as already mentioned before, we do have key performance indicators which we want to measure. So what is the proportion of patients of strokes within a country who are admitted to a stroke unit? And how fast are these patients admitted? And more interestingly, how many patients are not admitted to a stroke unit? How many patients do not have an access to standardized treatment approaches? What is the provision of intravenous thrombolysis and endovascular therapy overall? Access to stroke unit care. We want to also to know whether these patients have access to imaging, ECG, long-term ECG monitoring, cardiac echo, dysphagia screening, and blood tests. So according to our experience, it's much easier to measure the acute phase because then the patients are coming into a hospital, and most hospitals and most countries nowadays have at least local or regional databases. However, it is much more difficult then also to assess the access to early stroke unit rehabilitation. And I think we will have, it will be much more challenging to address these topics, the plan of rehabilitation support at discharge, follow-up at 3 months and to 6 months, and also secondary prevention measures. However, these are the aims of our stroke action plan, and these are the goals which we decided we want to achieve. So how can we do this kind of mapping? So we need a network, we need a partnership approach. ESO cannot do this without your help. So we need a strong collaboration in between the Stroke Action Plan Committee and the national coordinators, and therefore it's extremely important that Hanne is taking her time and is conducting interviews with all of you in order to address the specific problems in different countries. We have to know what your problems are, and you have to know what our problems are. So first of all, the professional societies are probably crucial for establishing and collecting these data, but we definitely need also the support of the stroke support organization. Otherwise, especially the domains of life after stroke rehabilitation cannot be addressed from our side. We need involvement of the Ministry of Health. In different countries, we have very good national data on stroke care, whereas in others, these data are not collected on a governmental level. We want to identify countries who have national stroke registries or at least regional stroke registries. And we know that there have been done a lot of initiatives to have international stroke registries, which probably are not covering a whole country, but at least are giving us some indications of a certain area or certain hospitals. We also need health authorities to help us collecting surveillance data on stroke care. We are liaising with other societies, especially the European Academy of Neurology and the European Society of Minimal Invasive Neurotechnology. These are the colleagues which are doing neurointerventions. We will liaise with WHO and European stakeholders and the European Commission. So before we started now this whole adventure, we wanted to know how many stroke registries there are in Europe. And we were mainly looking at national stroke registries. And here you can see the results of this first survey. You have already received surveys from our side. And this is for us is crucial, because if we do not know where these data which we are getting from your side, where these data are coming from, we do not know how reliable these data are. So as you can see here in blue, these are independent national stroke registries, which means these are registries within a country who are independent, but they try to cover almost all stroke patients admitted to stroke units and stroke centers within these countries. Also blue, you have the wide participation in international stroke registry. So these are countries where almost all centers are participating in international in the international stroke registry. Red means there is no national stroke registry, and in orange you have the countries where a national stroke registry is planned. So this will help us to grade also a little bit the evidence of information we are getting when we are performing surveys. We know that if you have a country where you have a nationwide coverage by a stroke registry, that the data on rates of intravenous thrombolysis, endovascular therapy, stroke unit admissions are probably more reliable compared to a country where you do not have a national registry. So the data sources will come, however, from a broad range of sources of information on relevant indicators. So as already mentioned, national and regional stroke registries, international stroke registries, public health surveillance data, and collection of aggregated data across stroke units or stroke or comprehensive stroke centers. So for instance, in a country where we do not have national registries, the national coordinators still have the possibility to contact directly all stroke units and stroke centers and try to collect these data from these people. And then we will compare the performance indicators across Europe, influence stakeholders and policymakers, and we aim to ensure optimal care to all stroke patients in Europe. As you already know, we have done this kind of exercise already before in 2016. This was the first time, and we have done a lot of mistakes, but these mistakes are now extremely helpful, because if we roll out for a next phase, we know where the challenges are and where the pain points are. So yeah, I just briefly want to recall you, here you have the monitoring which we have done in 2016, and what you can see, we have a massive inequality between European countries in 2016, but also within European countries in provision of stroke units and stroke centers. Again, also at that time, we were struggling that there was no common definition of a stroke unit throughout Europe. So that's something which we will now address during the next survey. Second, we were looking at IVTP rates, and also here massive inequalities and endovascular rates. And we are confident that in the meantime, these numbers have changed. And therefore, if we really want to measure, we have to collect these data again. And that's the reason why we will spread out soon. We will contact you within the next few weeks, and we would like to collect you again the same numbers which we have done in 2016. However, we will ask you not only to provide data of 2020, we also want data of 2019 for obvious reasons. We know that in the meantime, we are facing a pandemic, and this had a major impact also on stroke care throughout Europe. And if we want to see the improvement of stroke care, we have to make sure that we also address the impact of the pandemic on the whole chain. So we will ask you to provide us data of number of stroke units and stroke beds in the country in 2019, 2020, number of IVTP, endovascular during these years. And we will also ask you whether you think that the GBD data, the global burden of disease data for your country, are accurate or not. I remember we had a lot of discussion with different people in 2016, 2017 saying, well, these data probably not longer accurate in our country, and we would love to get your feedback because we want to improve these data. In the future, how we are going to measure these KPIs, we will have a web-based, user-friendly database, and we will contact you then on a regular basis so that you can enter these data directly in this database. database. This will be academic REDCap database. And you will access this through our website. It will be password protected so that not everybody can just simply look at these data. And we want to know where the data source is coming from. Why are we doing this? We want to streamline and be more efficient in information gathering. So in the future, we want to have updated information every single year on the progress of the implementation. We want improved assessment and comparison of data quality and methodology. We want to have an improved information access. We want to accelerate the comparison across countries and over time. And we want to give promotion of national and international joint cooperation, because based on these databases, we eventually will see that some countries in some areas will face the same problems and probably could benefit from the same solution. We also want to make that comparison is readily accessible to stakeholders, because if you go to your government in a country like Switzerland and saying, well, we are doing poor compared to Germany, this may have a bigger impact than if we say we are doing poor. So if you have a comparator, you then can improve a tailored strategy to improve the quality of care. So an annual data upload will then be key. It must be flexible, and we do want to be inclusive. So we do not want to make it too complicated. However, certain KPIs will be more challenging to be measured. We are completely aware of this. However, if we do not try, we will never ever aim to reach our target. So this is how it will look like more or less in the future. I will not go into detail, but this is a REDCap system. Trialists are very familiar with the REDCap. That's an easy database which then can be used. So the long-term goals are to have a more common definition of quality care indicators. We want to have an IT infrastructure for continuous online registration, and ideally a real-time feedback supporting continuous improvement of care throughout Europe. How can we get there? We will consult the countries. So Hanne will take her time, and she will have these interviews with all of you. And if you have problems, if you have challenges, please communicate to us. Without your feedback, we will never ever be able to achieve this goal. We will have a catalog of national surveillance information, and then we will have to test it. We have a pilot phase, we have to validate, we have to improve, and we have to learn. It is clear that from the very beginning, the system will not be ideal. Different things will not work. However, we are here to improve, so we have to define the things, we have to take measures, we will collect data, we will analyze these, and then we hope to improve. However, it is very crucial that you give us your feedback and you help us to improve stroke quality throughout Europe. So implementation and delivery of the key priorities is what we aim for: mapping stroke care, critical analysis, mapping stroke care needs, and then taking actions and producing recommendations. So thank you very much for your attention.
And thank you, Urs, for this excellent talk, going far beyond the few slides I sent you. Everybody, please send us questions for Urs using the chat. There are already some questions there.
I think one of the questions was whether the people can get the presentations. Obviously, you can get all these data. It's shareware. We want to be inclusive, and you can have the presentations after this meeting.
All the presentations are always posted on the website of SAP-E, as well as the meetings are recorded, and there's free access to go and listen to the talks once again if you should feel like that.
There is a question from Aline. Can you remind us what is data collecting is going? When it will start? Yes. I mean, there are two things. Obviously, the acute care survey will spread out soon within the next few weeks. We will start again with a pilot phase because we want to see whether we have tested the survey and but we will start with few countries, one in the north, one in the south, one in the east, and one central. And as soon as we have the feedbacks of the national coordinators, and if they are happy with the pilot or test phase, we will then spread out. And we hope that data are collected until this summer. The overall, the RedCap database will then hopefully start this summer. So that's our aim, as I have seen on the slides of Hanne. Please correct me if I'm wrong.
No, dry runs in summer, but data collection then ready for end of year.
Yes, so but in the meantime, we want to get the data of 2019 and 2020 for obvious reasons, because, you know, I'm pretty much convinced that in between 2016 and 2019, there was an improvement of the stroke care throughout Europe. And then I think, or that's our hypothesis, that might have been a drawback in 2020 with the pandemic, when quite a lot of patients could not be admitted due to obvious reasons. There are other questions coming in. There was one from Susanna Ktovina, that it is about the definition of stroke unit is not the same in countries. Yes, I mean, the European Stroke Organization has once set the definition of a stroke unit. And you know that we have the documents. However, not every stroke unit is a stroke unit. It's not always what is called a stroke unit is also providing the same services. So therefore, that was what I meant when I said there was not a common definition. There is a common definition on stroke unit, but it's not applied or used the same way in all countries. There is also a feedback from Janika Kurv. Before starting collection of data, we should define the criteria for stroke units. The current definition is difficult and confusing. Yes, we will address this also in the committee, and you're right. I mean, that the common definition is crucial if we want to collect this data.
We will define this. We have, I assume, according to the definition used in the action plan for stroke. You go to the paper, there's a table 1 with the definitions.
Just only to mention, we are collecting the definition of stroke unit in the next survey, which will be sent out. So we will ask you, what is the definition of a stroke unit in your country? And there we will have more information on that topic. And this will help the steering committee in order to address this for future surveys. Okay, I don't think there are any further questions now.
Then I want to thank you once again, Urs. We are slightly ahead of time, which is always a nice surprise. Then I would like to introduce our next speaker, Professor Torsten Steiner from Frankfurt, who has been a long-standing chair of the guideline board of ESO, and now also took upon himself to lead the work of setting up a basic care manual, including how to do this. So Torsten, thank you for joining us today. We're looking forward to hearing your talk.
Thank you very much, Hanne. Dear colleagues, it's a pleasure to talk to you. I'm talking about the basic care manual. So what is the basic care manual made for? It is made to assist the implementation of the ESO action plan in countries in Europe by providing evidence-based care and treatment, and by defining good basic stroke care over the chain of care from pre-hospital setting to life after stroke. What is this basic care manual not? It is not a guideline according to the standards of the ESO guideline. How was this basic care manual prepared? There was a subcommittee established by the ESO guideline board on request from the Stroke Action Plan Implementation Steering Committee. This group consists of Guillaume Turk, Jesse Dawson, Katharina Sunnerhagen, Hanne, and myself. How did we, what was the method? We always tried to get high quality guidelines and translate them into a practical list. So we started with ISO guidelines wherever they exist. If there were no ISO guidelines, we then used other guidelines that followed the GRADE approach. If there was no guideline according to the GRADE approach, we then looked for existing guidelines that were based on consensus. This, the current version, which I'm presenting to you, was approved by the Implementation Steering Committee of the SAPI, the ISO Guideline Board, and the ISO Executive Committee. What is covered, as I have said, it covers a list of recommendations over the chain of care from pre-hospital phase to life after stroke. We introduced a little bit of a grading scale, very primitive, only in must do, consider to do, and don't do's. We also wanted to provide the quality and the type of source the different recommendations are based on. And we differentiate between evidence-based recommendations, systematic reviews, meta-analyses, randomized control trials, consensus statements, and research articles. The aspects that are covered are pre-hospital management, arrival with suspected stroke, perfusion treatment, initiation of pharmacological treatment, acute stroke care, stroke rehabilitation, prevention of complications, further workup, pharmacological secondary prevention, carotid disease, non-pharmacological secondary prevention, after discharge recommendation, and life after stroke. Pre-hospital management, we recommend educational campaigns to increase awareness. We also recommend that emergency technicians and paramedics are trained in a simple way and using scales to identify potential stroke patients. There should be code stroke protocols implemented. Don't do's are the routine use of O2, at least not as long as the saturation is above 95%, not using insulin and not using hypothermia in the pre-hospital setting. On arrival of suspected stroke, there should be pathways established in each of the hospitals / stroke units. People who are involved should use a routine clinical assessment, including rating scales. There should be the possibility of immediate imaging studies, CT and MRI, and CT and MRI angiography in those patients who arrive within 6 hours when they are, or those who are eligible for a recanalization therapy. If there are patients who are eligible for EVT or IVT within 6 to 24 hours, again, we recommend that it is possible to perform imaging studies, including angiographies. Blood workup should consist of at least APTT, INR electrolytes, creatinine, and a blood count, plus EEG. But all these should not delay reperfusion therapy. We recommend to consider the use of certain MRI protocols, MRI and MRA protocols. Acute treatment includes the measuring of glucose before IVT. IVT should be done within 4.5 hours. IVT and mechanical thrombectomy in large basilar vessel occlusion should be done if patients can be treated within 6 hours. And then reperfusion therapy, IVT, and or mechanical thrombectomy can be performed in patients who arrive in the late window. Initiate acute pharmacological therapy comprises of aspirin, 250 to 300 milligrams, blood pressure control below 185 over 110 in the first 24 hours after IVT, and mechanical thrombectomy. In ICH, blood pressure should be lowered below 140 millimeters of mercury. Seizures that occur within 7 days should be treated with anti-epileptic drugs for 3 months. If the seizures occur after 7 days, long-term anti-epileptic therapy becomes necessary. In ICH, you should consider reversal therapy if these ICH relate to oral anticoagulation. Don't do's comprise of blood pressure lowering in ischemic stroke as long as the pressure is below 220 over 120 millimeters of mercury. Systolic blood pressure should not be lowered by more than 90 millimeters of mercury in acute ICH, and we regard it as don't do to use anti-epileptic drugs for primary prevention in ischemic stroke. Acute stroke unit care includes that all patients with suspected stroke should be treated on a stroke unit on arrival. These stroke units, it should be possible that patients will receive swallowing screening within 24 hours by feedings by a specialist. Patients should be sit out of bed, stand or walk at least within the first 24 hours where possible. There should be an initial screening and assessment by rehabilitation professionals within 24 hours. And don't do, if help is needed to sit out of bed, stand or walk, do not offer high dose mobilization in the first 24 hours. Concerning stroke unit rehabilitation, care and support discharge, all patients who require inpatient rehabilitation should be considered for specialized stroke rehabilitation unit. There should be a multidisciplinary team consisting of physicians, nurses, occupational therapists, physiotherapists, speech language therapists, social workers, and dietitians. There should be a basic assessment of components like swallowing, mood, cognition, temperature, nutrition, bowel and bladder function, skin breakdown, mobility, functional assessment, discharge planning, venous thromboembolism, prophylaxis. Patients and carers should be involved in the rehabilitation process. The rehabilitation team should follow a best practice guideline. Early support, we call for an early supported discharge, meaning that patients will be provided by plans for rehabilitation and for the time after rehabilitation. Don't do is to withhold stroke rehabilitation or even stroke treatment, stroke care for patients where it is uncertain, where the rehabilitation potential is uncertain. Prevention of complications comprises of intermittent pneumatic compression devices to prevent DVT and pulmonary embolism. If this is not available, low molecular weight heparin should be used for prophylaxis. It is important to prevent urinary tract infection, to prevent delirium, to prevent falls. We regard it as don't do's to use compression stockings or unfractionated heparin, except for those patients with severe renal failure. The use of indwelling catheters should be avoided. Further workup of stroke during stroke unit stay comprises of glucose measurements, lipid measurements, and liver status. There should be repeated blood pressure measurements at least every 15 to every 30 minutes, depending on the patient's condition. There should be telemetry at least for 24 hours or more on pressure, rhythm, and oxygen. Clinical assessment of structural heart disease should be implemented. Carotid disease, the diagnostics of carotid disease should include Doppler or angiography, CT or MRI angiography. There is additional monitoring recommended in those patients with suspected cardioembolic mechanism who may be in need for oral anticoagulants. Consider the use of echocardiography whenever there is a potential cardiac etiology suspected, and CT angiography for large vessel disease in aortic arch or interstitial, for disease in the aortic arch and interstitial vessels. Pharmacological therapy, secondary prevention is certainly a personalized and individual treatment. It depends when these therapies are applied to patients. We should consider the physical and cognitive disabilities of the individual patients. Secondary prevention measures should be commenced as soon as possible. Antithrombotic therapy within 24 hours. The aim of antihypertensive is a blood pressure below 130 millimeters of mercury, may be higher in patients with bilateral carotid artery disease or elderly people. The choice of the drug vary according to local practice. Long-term treatment with statins should be offered to all people with ischemic stroke unless there are contraindications or other obvious reasons for other sources or causes of acute ischemic stroke. In patients with ICH, statins can be given if another indication is present, but are not routinely needed in ICH. Antithrombotics, meaning should be given in case of no atrial fibrillation. These should be and consist of long-term antiplatelets, if not contraindicated. In case patients have no atrial fibrillation, in patients with atrial fibrillation, long-term anticoagulants should be used. The choice of the drug, again, will vary to local practice. We recommend to consider the referral of individual patients for closure of patent foramen ovale in patients younger than 60 years and with no alternative cause of the stroke. It may be considered the use of left atrial appendage occlusion may be considered in certain patients with atrial fibrillation, and in patients with intracranial hemorrhage, we recommend to either include these patients in a trial or to consider the restart of long-term oral anticoagulation, or in individual cases, which is not written here, the use of left appendage occlusion. Don't give antiplatelets to patients with atrial fibrillation and don't bridge heparin before initiating anticoagulants. In carotid artery disease, we recommend as a workup to use ultrasonography, CT angiography, or MRA within 48 hours. If there is a stenosis of more than 50% according to NACID criteria and symptomatic stenosis, people should be referred to vascular surgeon. CEA or stenting should be preferably performed within 40 days of the stroke, and CEA is preferred over stenting in people older than 70 years. Non-pharmacological secondary prevention, lifestyle modifications, comprise of advices to stop smoking, advices to limit alcohol, guidance on diet, meaning fruit, vegetables, to reduce saturated fats and to reduce salt, also exercise and physical activity. After discharge, it is important to involve patients and relatives to ensure that needed care is provided to patients also after discharge. Blood pressure should monitor regularly after discharge from hospital and follow up on pharmacological and non-pharmacological secondary prevention needs to be planned for these patients. Life after stroke comprises of aspects like follow-up. Patients should at least be advised to use post-stroke checklists. They should be referred if needed. Also aspects comprise, or other aspects comprise of support and of education on advices how to deal with driving assessment. There should be an individual assessment of patients. Also, these aspects relate to relationships and sexuality, disability support, advanced care planning, and the transition to long-term care, meaning things like discharge summaries and care plans should be handed over to personal patients and relatives. Thank you very much.
And thank you, Torsten. This was a tour de force of listing of good advice as retrieved from various care guidelines. I will now give the work to Urs, who will handle the or chair the questions, which I encourage you to send by using the chat.
Yes, so first of all, congratulations, Torsten, for all your work and these excellent manuals. Please use the chat function. I then can ask the questions to Torsten. So Torsten, again, do you think, how will this document which you're creating be in addition to our current guidelines? So what is the additional value and how is it linked to the system we are using today? Because, you know, ISO guidelines are extremely important, and I would like to thank also the current executive committee who emphasizes the importance of having up-to-date guidelines.
I think, as far as I have understood the process, these are supports for minimal standards of stroke unit care, of stroke care, in the process of improving stroke care all over Europe. As I said, these are minimal requirements. As far as I have understood from the discussions, they are not recommendations.
Excellent, thank you. So there is one question from Björn. Carotid endarterectomy within 14 days, but not 7, like the American Heart Association, American Stroke Guidelines. What is your comment?
Here we have a problem. I mean, we cannot have a basic stroke manual without saying anything about operation. And as I said, these are the minimal requirements. They do not replace recommendations. So in case, as I understand it, so in case we have a system where it is a problem to install these the recommendations, this is at least the minimal standard. But certainly, if it can be done, we should follow recommendations in each of the systems.
Have you also considered, when writing these kind of documents, to have different levels? You know, we have countries where the stroke system of care is more established than in others, that we do have 6 different levels, which we can say, well, for this region, level 1 that's the minimal requirement, but for others, this needs to be even better.
That's interesting. I hope this will be maybe this is one result of the ongoing discussions on the SAPI, how to install this. But it's certainly a very interesting idea to have that.
Okay. Are there further questions to Thorsten? Currently, there is one coming in. Thank you. What about stroke survivors who are at higher risk, less ideal stroke survivors? For instance, the patients with comorbidities, post-COVID, pneumonia. So should we follow the same regulations and the minimal requirements as in the others? Or is this a tailored approach saying, well, this is for the first ever health and fit young strokes, or does it apply to everybody?
As far as we have discussed it, this first applies to all stroke patients. I think this document is not a document where we can base on a more individualized treatment of stroke patients with COVID, with comorbidities. I think these, as I said, these are the minimal requirements, and this should apply to all stroke patients.
And where are we going to see these minimal requirements? Will they be seen on the web page? Will there be a publication? So what is the current approach?
As far as I've understood, we are aiming for publishing these basic requirements, I hope in the European Stroke Journal. At least that was the plan. And I'm pretty sure they will then also appear on the homepage. Okay.
So this was a question which was also asked now by Aleš Tomak. Then there is a question from Arlene. Where would the recommendation to review the mental health of individuals covered in this manual? I don't know whether you can see the question.
Yeah, I see that. They are in. Thank you for the applause. They are, you may recall the last before the last slide. There we said it belongs to basic requirements of stroke to regard these individual needs of patients relating to cognitive dysfunction and so forth, but they are part of it.
Okay, there's one question from Danilo Toni. He's asking, somebody used the term basilar large artery occlusion, and he wants to ask what is meant by basilar large artery occlusion.
Danilo is right. The basilar artery is large on the whole length of the artery. Thank you.
Okay, good. Any further questions, comments, criticism? We are really open to get your feedback, and we do not only want to have applause, we also want you to be critic about our work. Otherwise, we cannot improve. We only learn if we get criticized in a constructive way, by the way. Further questions?
Then I want to thank you once again, Thorsten, for your great work in this and for taking the time to present here today. The next item on the agenda is the learning program, and I'm welcoming Professor Christina Tui, also a member of the steering committee of this, the SAP-East Implementation Steering Committee, who have been working on this together with Valeria Caso. Welcome, Christina. Looking forward to seeing your presentation.
Okay, all right. Can you see the slides?
Yes.
Okay. Good. So I put up together, together with Valeria, a list of educational resources. And maybe one can ask why a list of educational resources. We are in an era of a lot of information which is available just a click distance. If you look at the curricula for which is formulated in the European Union of Specialists in Medicine, the OMS, for neurology, so we have 4 years of residency and 1 related specialties for 1 year. And this is the duration of postgraduate training in almost all European countries. And the curricula for the cerebrovascular disorders, you look here, it's including mainly all the types of strokes and some other cerebrovascular disorders. The same document is stipulating that within a training center for neurology, there should be a wide range of clinical services available so that the trainee will be able to see and contribute to care of all common neurological problems. So they should have also outpatient, and they should have the occasion to work with different subspecialties in neurology. But obviously this usually does not happen. You start the residency working in, maybe you will work in an epilepsy center or in a park movement disorder center, and some of them will work in a stroke unit. After residency, more than 2/3 of the specialists will work in the ambulatory system. And so we thought that as SAPI is addressing all the steps in stroke care, from prevention to life after stroke, also neurologists from the ambulatory system, neurologists from hospitals, and also other specialties beside neurologists should be informed about stroke care. There was a work of Sonia Abileira on behalf of the ESO, ESME, TIN, and SAFE survey on stroke care collaborators, which found out that from 44 countries which were participating to this survey, 28 provided professional education, and there were 26 providing community education. So you have already seen this slide today. It's one of the most known surveys in the last years. And you see here the number of stroke units. And of course, if we ask ourselves who will benefit from these educational resources, we can say that medicine is a never-ending learning story. But for sure, the highest impact will be in countries with less developed stroke networks. And if it was also said before, we should know how a stroke unit or a stroke center is organized. And there are rules, and of course everybody is aware of them, but we thought also it is important to be put in these educational resources regarding how to establish a stroke unit and the stroke center. And if you look here on the right side of the slide, how a stroke unit is supposed to function according to the paper published by the ESO Stroke Unit Certification Committee. Most of the people from Eastern European countries will see that we still lack to be conforming to these requirements. So it's time to get certified, and everyone should be aware of the content of this paper and try to improve things and to make stroke units to be stroke units at least, if not stroke centers. So again, asking ourselves who will benefit, of course, the physicians. And I tried to I will point out some of the resources. And Professor Bornstein was texting in the chat just a few minutes before about the roadmap, which was written by the World Stroke Organization. And it is here. It is a very well structured document. It is available also in 8 languages. I think it is very important to have it translated maybe in other languages. And you see here there are a lot of items in the pre-hospital and emergency stroke care is covered, of course, stroke system development, acute stroke care, rehabilitation, and there are 3 appendix which are containing the steps to adapt the global stroke care guideline for local use. And there are some case definitions for acute stroke, and also some reference to international guidelines. And I put here this example of codification, but because even this was a problem. For example, in Romania, we still struggle to have a coding for the procedure for IV thrombolysis or endovascular treatment. And so this is also some item which is important. Going further, we selected Angels initiative, and I think most of, again, Central and Eastern European countries have benefited from this initiative in the last years. I would say that a part of the progress that is registered in Eastern countries is due to this initiative, because it came with the know-how, with practical advices to organize things in order to perform IV thrombolysis. There are these awards, which of course are honorific. It's a diploma, but they are working, and everybody wants to be assessed as a gold hospital or a platinum. And for the centers from which are not participating in the rescue registry, World Stroke Organization has organized a similar kind of awards. And the site of the Angels Initiative contains this Angels Academy, which where we can find the modules for emergency services, hyperacute, CT imaging, decision making, and post-acute stroke care. And of course, there are information about how to organize a stroke care supply chain and set up a stroke unit. The EIN resources are available just for the members of the EIN, and they cover the ischemic and hemorrhagic stroke. Of course, we have also the guidelines, and more or less all the countries have national guidelines. Usually they are adapted from international guidelines, ISO or American Heart Association. And well, it is in smaller countries or countries who does not have so many resources or a large number of specialists, it's a little bit difficult to maintain them updated, because the same people are meant to update the guidelines from all neurology. So here is some work to do, and simple indications like the basic care manual, I think, can fill a little bit the gap. And of course, we take the opportunity to welcome ISO guidelines for acute ischemic stroke for intravenous thrombolysis. Now we are going further to another category who can benefit from this list of resources. The nurses, there are here a lot of sites. One program is stroke training and awareness resources, the STARS. There are covered a lot of domains regarding stroke, and this site is structured like for each item we have knowledge, skills and benefits, the background and common symptoms, and then you get some skills and the benefits for the individual. who is following the program. Again, Angels Initiative has stroke nurse certification. It is an e-learning program which is structured in 20 modules and covers all aspects of stroke patient care. And it is already translated in several languages, so it can be accessible. And the training properly, the nurses can lead to initiatives like the QASC initiative, who was a program initiated by nurses in Australia with simple measurements of glucose and fever and assessment of dysphagia, who led to a decrease in mortality of the stroke patients. NICE is also having an interesting program. There are the NICE pathways, and so there is, I just put here the example for stroke rehabilitation, because it's an important objective, and again, it is underdeveloped in Eastern European countries. And for each item you have this pathway, and there is at the end also an assessment of the individual performances. And it goes to in cascade, and you open one window after another, and you can follow a lot of these items. And it's important to understand what rehabilitation must be organized, and to have these multidisciplinary teams. And some of the functions in this multidisciplinary team, like occupational therapist or logopedist, are still very very underdeveloped in the eastern part of Europe. So we are coming to the last part with stroke support organizations and information dedicated to patients and carers. Again, World Stroke Organization has a very well-organized toolkit for stroke support organizations, and it is divided into two main parts. One to help starting an SSO, and to help grow a stroke support organization and to increase influence. And the advices are to start with a small organization with people which are enthusiastic and very determined. And then there are a lot of advices how to attract funding, and how to organize things, and to advertise the actions of the stroke support organization. Among informations which of course can be useful not only for doctors but also for patients, it is a stroke riskometer. It's an application that was very well appreciated. It won also a prize in 2014, and it's based on questions which are scientifically based, and you can evaluate the risk of a person, 5-year risk or 10-year risk for stroke. And well, this can help to educate people to have a healthy lifestyle. Also, Safe Alliance has a toolkit for this stroke support organization. It is called SOFT, Stroke Support Organization Faculty Tool. Again, it has 6 modules regarding how to start stroke support organizations, how to use the evidence, how to have some health system advocacy and public advocacy. And you can follow these modules. There is free access, and this interactive training, it can be followed by a test, and then you can obtain a certificate. So This is, of course, a list that should be continued. This is an open list. It includes resources that were not presented because it was too boring to have a list of websites. And you are all invited to contribute to this list, but because, of course, we could not maybe find all the resources, existing resources. And I think that national coordinators should advertise this list, and the most valuable resources should be translated in local languages in order to increase the access of medical personnel, patients and carers to information. Thank you.
Thank you, Christina. An excellent overview of your work. I would kindly ask Urs once again to chair the Q&A session. Thank you.
Yeah, also thank you from my side, Christina, for this really excellent overview. There is no question yet in the chat function. Please use it, and then I will be able to ask the question to Christina. Let me start with the first question, Christina. You have mentioned quite a lot of teaching activities. Are there somehow already too many activities, and how should we try to focus a little bit or to canalize all the teaching activities?
Yes, I think one can get lost among all this data. So this is why I said the national coordinators will have to look upon the resources, the local resources, and what are the needs for education, and to select and to advertise those resources they consider more valuable and more useful for their country.
There are a lot of educational activities also from the ESO side, targeting mainly for younger colleagues. How will this be in line with the current or the educational activities you presented here?
This is actually a list of educational resources that any individual can access if they want more information. And I don't think there is a contradiction with ESO. I think we all have to learn as much as we can. And well, I don't think it's a contradiction.
Okay. We had a lot of discussion about education of stroke physician. What about education of neurointerventionalists? You know that training of neurointerventionalists is also a main aim in the whole stroke management. And we know that we do not have enough of these people in certain countries. So what are the possibilities nowadays, and how should we address this?
Well, ASMINT has a training program, but it cannot cover all the needs. So we are trying to organize in, at least I will speak now for my country, in Romania. We are trying to implement a local training program with a surveillance of specialists from ASMINT. But I think one way to increase the number of specialists is to admit also, beside radiologists, also neurologists and neurosurgeons who want to specialize in this field.
And what do you think are the main obstacles, I mean, for training neurologists in neurointerventions?
Well, the first would be that the radiologists are not so happy. The second is that for local programs, you have to have centers with a large number of interventions. So if you have 2 or 3 trainees on a center that is not performing many AVTs in a year, that will take longer to instruct them.
There is one comment from Björn. We need to strengthen the Master in Stroke Medicine program.
Yes, I'm sorry, I forgot to mention the master programs, because I was the beneficiary of one master program organized by Professor Brainin. So I'm sorry. And I take the opportunity to say hello to Professor Wilfred Lang, who was the conductor of my thesis.
Okay. There is another question. Also whether language barriers on the different professionals could be a problem. You know, we do have a lot of programs or documents which are written in English, but especially for nurses, therapists, language can be a problem. And how can we
Yes.
address this? Should we have should we as ESO try to finance or to translate the most crucial documents in a local language, or what would you suggest?
I think the societies can assume the translation of this document. They are not so large, but it maybe ESO could mediate, I don't know, the permission to translate, because there are some the work, the intellectual property of the one who created. And of course, this is an important issue, the language barrier, because 2 or 3 years ago, when it was organized by ESO East teaching course for nurses, I had big difficulties to find an English-speaking nurse to go to this teaching course.
Yes.
So
I think the language barrier is something which we definitely have to address in Europe, and I think there are probably crucial documents which should be made available in local languages. There was the question of Björn, what is the definition of a stroke physician? Are you aware of a definition of a stroke physician?
No, but even if it is, I do not know a definition. I know that there are differences when you are a stroke neurologist. So you are involved and you are aware of all these things that are written in the manual, at least in the basic one. It is different from a person who is not taking care of acute stroke patients.
Yes, I think that's an important point, probably also from my side. In the past, we had a lot of discussion, what is a stroke physician, and it's not the same in every country, and therefore we have to be a little bit broader. In many countries, stroke physicians are neurologists, but that's not unique definitions. We know that in some countries, geriatricians are the ones who are managing people with stroke. So there is another question from Igor Sibon from France. Would it be possible to develop a specific stroke program for non-neurologists involved only in the acute or chronic stroke management?
Well, maybe.
So I think what Igor, if I understand his question correctly, is that one problem is that most programs or educational activities are tailored for physicians, but we also have non-physicians and non-neurologists who are dealing with stroke patients. So is there a possibility to develop a specific program for non-neurologists involved in acute stroke management? I mean, from my side, probably if I can answer this, I think the stroke master which we had in Krems was not tailored only for neurologists. You could also as a geriatrician. And in the future, the stroke master program will also be open for non-physicians, so that if you have even if you are having a master degree of another field, you will be able to enter this stroke master program. Then Nathan Borstein was mentioning that the United States, the Americans, they have a certified stroke neurologist. Maybe
well, they have everything. So
it's a very good point. So the comment of Nathan was maybe ESO should aim to have a board certified stroke neurologist. We know that, for instance, ESMINT is having ESMINT certified neurointerventionalists. Should we as ESO aim for the direction of also certifying stroke neurologists? What is your opinion on that?
Here, of course, you can have this kind of certification, but because we have stroke is such a big problem, public health problem. If you just say, okay, only certified stroke neurologists can take care of stroke, I don't think this is something that we want.
Yeah, I think that's also something which we had a discussion also when we discussed on the stroke units and stroke centers. You remember that we set up a definition of stroke unit and stroke center in Europe, and we started to certify stroke units and stroke centers. But you know, there are also countries where you have a country-specific definition of a stroke unit and stroke center, which is always the same as the ESO definition. There is another question from Dmitro from Ukraine. Probably it should be unified education program for stroke physicians so it can be adopted locally in every country. What do you think on that?
Well, yes, but we can think and implement a curricula, well, to contain like basic knowledge or different level of knowledge, because in the end, again, you learn all your life. So it is related to the last question regarding certification as a stroke neurologist, because if you do not have a definition for stroke neurology, if you do not have a curricula for certification, then you do not have what to unify. So it's just to have all the knowledge you can absorb.
Yes, so I think what I think should be highlighted again, that in the past ESO was supporting or creating a lot of educational activities. I would like to mention again the summer schools, the winter schools. We also have winter school on research, which is currently ongoing in Edinburgh. We have the Stroke Master program. So I think there are a lot of teaching activities, and last but not least, the conference and the Congress is the flagship of ESO and is also having a very important teaching part. Are there further questions? If this is not the case, then I would like to hand over to Hanne.
Thank you, Urs. The next item on the agenda is the regional breakout sessions, which are supposed to start at 10 to 2. I have tried to find out from those who provide this system if we could start a little bit early, but I've not yet had a response. But now we go for break, and then I will assume that it is possible to reconvene not at 10 to 2, but at 20 to 2, so that we can rather stop 10 minutes earlier than have a longer break. So meet you again. You go and your link will go directly to the breakout session, depending on your geography, and we will reconvene at 20 to 2. See you later.
See you.
See you.
And I'll turn the bell off.
Okay, that's perfect. I think I will just quickly text Hanne whether she wants to come back, those 10 minutes earlier that we were ahead, or whether she wants to, add this to the about time.
Take advantage of the extra time.
Yeah, let me see. Okay, so she just texted me 14:40 would be coming back. So that's actually then in 13 minutes.
So we're still 10 minutes ahead. And
Yeah, exactly.
Okay, I'll send a message to everybody in the room saying still back at 14:20 to the hour.
Mm-hmm.
Yeah, I'll do that now.
yeah, Catherine, and that, just to let you know, your mic is causing like a big audio hissing sound now.
Oh, okay.
Oh, it's gone now. Yeah, it's went then. Yeah.
Oh, strange. I didn't do anything. But
Huh.
now I can hear myself.
You can hear yourself.
Yeah, a little bit. But maybe then I can, put in the headphones. Maybe that's better now. Just checking.
We've just had that's better, but we'll get the hiss is still there. Yeah. Just to let you know, we've got a couple of people coming back.
Ah, yes.
Yeah, it's cool, and your headset is causing that hum again.
Not so easy this time.
Forsten has just rejoined us.
It goes to west. It goes to the north.
West, yeah.
West. Probably wondering now why he would go to the breakouts again. But that's okay.
So just checking, everyone's coming back from the breakouts and going straight into breakout discussions.
Yes, yeah. So Hannah will moderate, having them coming back, and then they will do their little presentations.
Yeah.
And then once everyone is left, we can leave the main room open, and those of the steering committee who would stay to have this little recap, they can stay.
Okay, perfect.
So everyone is staying. Probably, I mean, I did make this invitation, a little bit longer so that they should know that they have to stay. But you know how it is. So we'll see.
It's whether they read that bit of information.
Yeah. It's
Thorsten's back again.
Hello, Thorsten. I think you can stay with us in this main room now because the breakouts will end in about 7 minutes, and then everyone will be back in the main room. Otherwise, we could put you in this breakout room where Germany is. It depends.
Just to let you know, Catherine, your mic sounds a bit better now.
Ah, good.
Yeah, I'm not sure what Thorsten's doing with his microphone or his links.
Yeah, it's strange. Huh.
And he's back. I think he was trying to get his microphone working because it looked like he was trying to say something.
Yeah.
Mm-hmm.
Hi, can you hear me?
We can now, yes.
That's something. It's funny. Anyhow, I couldn't talk to you, though my microphone showed me that I'm actually on.
Yeah.
Anyhow, I was trying to get back to the meeting and had again the problem that I couldn't hear anybody. I could see them. I could see that they were talking, but I couldn't hear them.
Okay. Well, you have a choice. You can either remain where you are now because the breakouts are due to finish in about 5 minutes' time, or you can go and join the breakout room again for the last 5 minutes. The choice is yours.
And what do I do if I do not get in now?
Just stay where you are and just go on to mute and camera off, and everyone will come back within the next 5 minutes.
All right. And if I go back to the room, what happens then?
You would just join the breakout room as you have been previously, and then within 5 minutes we'll be closing the room, bringing everyone back to the room that you're currently in at the moment.
Yeah. Perhaps you can bring me back to the room because I saw that there was a slide on the basic manual, and that was what I was giving the talk on.
Okay, Leslie, are you able to arrange that?
On your way.
Let's see.
Catherine, I'm thinking that for future ones, and that it's if you're able to include in any of your communications, especially with the presenters, and also the delegates as well, the attendees, just in that making sure they're running the most current version of Zoom, just in case they're running a really old version that's missing certain features.
Ah, okay. Yeah, I can do that. That's no problem.
Because it could be in theory, if you don't see breakouts, Catherine, that you don't have the latest version of Zoom.
Ah, okay.
Are you on a web-based or are you on your app?
No, I'm at my laptop web-based. So.
So you're using the browser version rather than the Zoom application.
It is an application, but it's.
Okay. Yeah, so proper Zoom install as such on your computer.
Mm-hmm.
Yeah.
So in theory, if you go to your profile and go top right, there should be a check for updates.
Ah, okay. But maybe that it always is a little bit tricky with our IT because usually they do the updates.
So they centrally manage all the updates and then roll them out to everyone in one go.
Yeah.
Yeah, because
but I will check. I will check with my team if they have, when the latest version was updated or when we had the last update, let's say. And
the current version is, let me just do that quick check.
I mean, it updates at least once a week usually.
Yeah, and it's on version 5.52 at the moment, which is the most recent version. I know about 2 or 3 versions ago they introduced, and we've just got Anita back.
Right, okay. We're 2 minutes off closing. I'll send Anita on her way again. So
yeah, so about 2 or 3 Zoom updates ago, they introduced the feature for co-hosts to have full access to the breakout room options. So that's what may be in that. It could be you're running an older version where you haven't received that update yet.
Yeah, probably. Because when I see the icon breakout session now, but I can only join the one that you
Allocated you to one room at
right.
to start with, yeah.
Right, yeah.
If possible, see and from your IT, the reasoning why they're so slow at getting their updates to you, and because there may be a particular reason that they want to ensure that it doesn't breach any security or something like that.
Yeah, exactly.
But also find out if there's a way they could increase the amount of updates that come out instead of it being once every month for such, and once every 2 weeks if possible, or it depends on how their update cycle is.
Yeah, no, I will check with them and see.
right, it's now time. So should I close the breakouts?
Mm-hmm.
Okay, closing the rooms now. It's on a 15-second return.
Okay. And then spotlight Hannah as soon as she comes on.
Okay.
Yes, we are in the plenary now.
So, welcome back everybody to the plenary session. We're now going to have the presentation of the feedback from the 4 geographical groups. First, I would like to ask North to present. North is Jannica, I think, as far as I've been informed, who will also today report from North.
Hello. It's my pleasure to report from the northern part of Europe, and we had 14 participants in our breakthrough group today. And the first question was about the data reporting and presentation, and there are differences among the northern group. In many northern countries, there are mandatory national registries operating. Denmark, Sweden, Norway, and United Kingdom for several years. But in many of these registries, there are quite few data about after the acute phase, and mainly they are concentrating onto the first 3 to 6 months. For Finland, Estonia, there are data available and also some digital databases. For example, from Finland, the FinData, a new system which integrates digital data, and this also exists in Estonia. For example, from Lithuania, there are no governmental system for collecting data, and only stroke-related data are collected into the rescue databases. So most of the registries from northern countries cover a lot of the population. For example, about more than 95% of stroke patient data. About the manual, all countries thought that this is a good idea, and there was a suggestion from Estonia to have this manual in local languages, to translate it in local languages, which is much easier for many countries. But in many countries from the Northern Group, there are already national manuals available, national guidelines, and regular conferences are organized in most of the countries. And we agreed that this manual should be basic and should be available for everybody. And what about the learning program? Also, this all countries agreed that this is a very important activity to educate young doctors in many countries. For example, Denmark, all young doctors are trained in stroke units. But of course, the problem is that the northern countries some of them are very, very small. For example, Iceland, especially Iceland, because in Iceland and also in Estonia, stroke patients are treated together with other neurological patients. And for example, Finland, the problem is manpower. So in some places, the participation in the activities is a problem. And also there are deficit of doctors in the United Kingdom as well, especially during the last year, which is mainly the management of stroke patients is affected by the COVID situation.
Thank you, Jannica. Very, very useful feedback. I think we will go through the geographical areas, and then we will have a general discussion through the Q&A. So I would like to give the word to East. And at the moment, I am not aware who will present from East.
I will be presenting. This is Adam Kobayashi. Hello, Hannah.
Hello,
so
nice seeing you.
Nice seeing you too. Okay, so as for the three questions, so most of the first for the data reporting, most of the countries reported that there is no problem to acquire the data from regional or national registries, but some countries report that there might be a problem with having full data for all stroke patients, as registries are not necessarily compulsory to report all stroke patients. And one topic that was raised, that in the KPIs we should report long-term follow-up, because this, in some countries, this is a problem. The latest follow-up we have for the patients in some circumstances is that the day they are discharged from hospital. So this is the these are the two basic issues that we have in these countries. As for the basic care manual, we think that it's very useful to have to talk to authorities. We, of course, most of the countries have their own guidelines. In some countries, the guidelines are translated from English. But we think that maybe the guideline documents are not sufficient, especially for training of young physicians, or the basic care manual would be very useful for emergency physicians, or for departments that there is no specific stroke, that there are no specific stroke units for doctors that not necessarily are stroke or stroke trained. trained physicians. And the last point, we had a big discussion about this because we, of course, everybody sees the need for training. Probably in the COVID circumstances, it would be useful to have online training, but we perceive that there is that there will be a possibility for learning, undertaking a learning program, but this not necessarily would be compulsory. As for certification, this would be quite a big problem, as the stroke physicians have very often different backgrounds. So I think that to make one unified training program for all stroke physicians, it would be a bit difficult. As for the training of nurses, the very big job is being done by the Angels Initiative. So in fact, we think that the training of nurses within Angels is even better than training of physicians. And of course, a point that has been raised is that we should encourage, apart from creating learning programs or leading learning programs, we should encourage young physicians, young people to do stroke. So thank you very much.
And thank you, Adam. And from South, Christina Tui will kindly present what was discussed in this group.
Okay. Okay. All right. So we had a group of 18 participants, and our group includes stroke neurologists and representatives of stroke patient associations, and also we have speech and occupational therapists and nurses. So regarding summary data reported, one point that was raised by Massimo Del Sete was the fact that we miss in this summary data the patient-reported outcome in stroke survivors, and maybe it was suggested to introduce this. Also, regarding the epidemiological data, there are two problems. One is the very great difficulty to gather this data in countries where there is no registry at all, and it was a case of Cyprus. And another issue is when you have many local registries, like in Italy, it would be difficult to identify the coordinators who can obtain and aggregate the epidemiological data from all these local registries, because most probably the registries do not have exactly the same items they record. Of course, the number of ischemic strokes and so on, and hemorrhagic would be the same, but anyhow, it is difficult to obtain and also to gather this data in order to report them homogeneously. Also, it was raised an aspect regarding life after stroke, and it was stressed that it should be more strongly considered by SABI, especially for long-term survivors. Regarding basic care manual and educational resources, it is considered by all the participants, because nobody spoke against it, that it is useful. And more, it was considered that it has a huge potential to help the countries to see where they sit according to the basic care of standards. Because, of course, for countries more advanced, they say, okay, we already did this, and they will look for higher standards. But in countries where it's now the very beginning of implementing the idea of standard of care in stroke patients, this will be a very good point to start. For educational resources, it was asked for possible solutions, financial basically, for translation in different languages of educational resources, and we consider that this should be evaluated. How many languages, what materials, in order to evaluate if this is feasible. And it still was stressed the idea that the national societies, professional societies can maybe found resources considering the importance of the matter. Also, the idea of a basic standard for neurorehabilitation across Europe. Hannah stressed that this is included in the KPIs, and we now say for everybody that the steering committee and specialists from SAPI offer logistic support and any kind of material it is needed in order to develop this particular aspect. And also, it was suggested that a broader category of materials should be included on the website, not only evidence-based care. Now we have to understand correctly this. It was stressed that some evidences sometimes come after using a tool for a certain period of time, and it was referring especially to stroke support organization. And this was more or less were the discussions in our group.
Thank you very much, Christina. The last group, West. I'm not sure who will present from West.
Sorry, I'll present from West.
Yes.
All right, can you see my slides? I think so. Okay. So from West, we had 16 participants from different European countries. And regarding specific data reporting and presentation, the group had some doubts regarding quality of data and data accuracy. There may be some countries with some difficulties regarding collection of national data, and there are some possible issues that were identified. Like, for example, data coming from different sources. Some data will come from hospitals, regional registries. Some will be national data, so there's some heterogeneity in the sourcing of data. There may be some issues regarding data privacy and also data property. In some countries, there'll be probably some delay in data availability. In some countries, data is only available 1 year after the current year that it's analyzing. There were some different care settings during COVID-19 pandemics, and some countries may report some decreases in admissions. That may be some false reportings because data is not being completely collected. And this may lead to inaccuracy in numbers. Also, there may be some problems regarding coding of strokes or different events or outcomes. The group also thought it was important to have a small number of key comparators and to define what we mean by meaningful comparisons. Also, the group felt that workload may interfere also with the collection of data, and it would be important to have some support from ISO regarding data collection. What we suggest also to focus on rehabilitation, to have data regarding rehabilitation and life post-stroke, to collect also data regarding the number of different health professionals in stroke units, and collect also information regarding national certification of stroke units. This would be important to have homogeneity of terms, and also to have probably a description of a net of European stroke units. Know what's the current status regarding to European stroke units in Europe, and to also to help to uniformize terms and concepts, to have a national stroke unit certification cooperation with ASO representatives. Regarding the basic care manual, the group thought it was very important. It allows for standardization of terms. It may be useful for countries without guidelines. It's very practical. And we have some suggestions to build also an app containing the basic care manual and to translate different the European native languages so that it can be accessible to all. Regarding the learning program, we suggest to add a tool regarding how to organize the ACSSO, and also to add position articles regarding tools and tests to avoid papers, persons, individuals in ambulatory care, follow-up, and also to evaluate outcomes. And that's our feedback.
Thank you very much, Anna. That was very, very useful too. And now we will open for the general discussion using the chat room from the feedback. So please put your questions into the chat, and I will read aloud. As a general impression, I see that people want to have translations, which is an obvious problem in Europe, that we have so many languages, or perhaps in the other way around, it's something which is charming about Europe. But anyway, and that is certainly an issue to which we will have a lot of attention, and will solve as good as we can. Everybody are welcome to put in their contributions for this discussion. So far, there's absolute silence. Oh, but on the other hand, this is perhaps not that strange, because the feedback was very, very clear. It was very easy for me to make notes of it, and I will anyway get the slides, which we will, as we usually do, systematize and look at within the group. Now there's one message.
Now
Christina.
It is me just saying that we have included in the educational resources how to organize a stroke support organization. We have two.
Yeah. So if there are no more feedback, I just want to give everybody a chance for a little bit of feedback. I will proceed with a wrap up. So I will. I think this has been a very, very useful meeting today. I've been impressed by the positive feedback received overall, and the very, very good feedback from the groups, which will enhance our works and our collaboration. The next steps we have to take is that the national coordinators who work on finalizing the stakeholder analysis and form the national networks. As the next mapping survey will be sent out presently, which is also very, very important, following up on the last survey from 2016, so that we basically get a good baseline on what is going on at the moment. This will be sent out presently. It will first be tested in a few countries just to get the bugs out, and then it would be sent out to everybody. We do know, we are certainly aware that it takes an effort to fill out these surveys. We have worked hard, especially Urs and Diana, to make this as short and precise and easy to work with as possible. And we hope that you will find the time. No, we don't hope. We kindly ask you, we beg you to take the time to fill this out, because this is extremely important for both the action plan project, but I'm convinced also for the work to improve stroke care in all countries, that we get this common data set updated again, because this is really what drives change. So be prepared to receive this. Probably this can best be answered in collaboration between people representing national scientific societies, stroke support organizations, as well as those who may run the registries in the countries who have a registry in place. Then please, those of you who have not yet booked for a one-to-one with me, please look at the invitation and book at your first convenience. I really, really hope to get a chance to talk to all of you. You can book just the coordinator or together with more people if that is what would be helpful, appropriate in your country. In countries where there are more organizations or more language areas or whatever, it might be specifically useful if more people are involved, because we basically want everybody on board. The next step we will send to you as to meetings will be that we will be some workshops which we will plan in the more practical parts of this, including how to report data, etc. And we will send this out probably towards the end of March. The new website will be launched, this is planned mid-March. We will send out information on this, and please provide us with existing learning material in your languages, which you think is useful, and this would be a great help when we're compiling this. As Christina explained, this will be compiled under languages, and we want to have as many languages covered as possible. So please, everybody, send in what you got and think would be useful, and we will organize this. And then I want to thank you once again for participating in these rollout meetings. I do hope they have been useful for you. We will discuss issues of the individual countries during the one-to-ones, but please always feel free to contact us by email to head office through Catherine Pokrant, or send me an email if you have questions, if there's something you want to discuss, or certainly also if you need some kind of specific assistance, which could be a signed letter or whatever. Please contact us. We will try to comply as far as possible. As to translations, we will get back to you on this issue when we've been through with the one-to-one and got an overview of what this would actually imply, and have been able to look at what resources would be needed and how this could best be achieved, and in what way ESA would be able to assist. This would be all for today. There are no new comments or questions coming up on the chat. So thank you, and have a nice afternoon. Looking forward to where we can also meet in person and not only through Zoom, though this is far better than not meeting. And please remember to book these one-to-one. Have a nice day. Bye.